So we're going to kick off this virtual education series. My name is Bo Standish. I'm the CEO and one of the founders of 70 Surgical, and very happy to introduce Dr. Stewart now.
Welcome to everyone who's joining us remotely. It's a brave new world. My name is Geoff Stewart. I'm an orthopedic spine surgeon. I practice in Orlando, Florida. I've been in practice since 1996, so 24 years. I get a lot of referral business. I do a lot of revisions. Probably a third of what I operate on has had surgery before. We can flip to my first slide if you would. I do a fair amount of adult deformity along with my partner. Do about 200 instrumented cases a year. Used to be closer to 250. I'm kind of slowing down as I get older. I work in a level 1 teaching hospital, the local trauma center in Orlando, which does have an orthopedic residency program. My partner and I run the spine part of that residency. I also work in a small community hospital, which until about 6 months ago was partially physician-owned. It was bought out by a nonprofit. And that's where the 7D is based. I'm much more efficient in that hospital. The days I work there, I usually have 2 rooms, 2 teams. So my goal as I have scaled down my practice is to do more surgery in that hospital and less in the trauma center. I was trained, I did my fellowship with Paul McAfee in Baltimore, and we put in a lot of screws when I was a fellow, and we put them in essentially blindly. We would put markers in, get an x-ray, put screws in, get another x-ray. I transitioned in practice to C-arm-based screw placement as well as, feeling the pedicle when you need to. One of the issues is I'm left-handed, so the C-arm's coming in from my side, and constantly I'm wearing lead and bending over the tube of that fluoro. So if I do 4 or 5 cases in a day, I go home and my back's sore for a couple of days. And 7D has eliminated a lot of that. And go on. So we got the 7D for a trial early in 2019. I immediately fell in love with it. I did 7 cases in the week it was there. Basically as I've gotten used to the 7D machine and gotten more faith in it, I've stopped using C-arm for everything but a final x-ray and localization when you need to localize. If you don't have a known level to count off of, if I do a 2 or 3 or 4 in the sacrum, I don't bring C-arm until all the screws are in. But this eliminates the need for me to bend over the C-arm so I can stand directly next to the patient. I don't have to lean over at a 70-degree arc at my lumbosacral junction. My back is better than it's been in the last 10 years. So fluoroscopy we use literally only to localize and to get a final x-ray. I've done over 100 cases in the past year. It's enabled me to transition patients from downtown to the smaller community hospital where the patients are treated well and I'm treated better than I am at the trauma center. This technology really changes. It's a game changer for deformity cases. I do a fair amount of deformity. I could probably put in lumbosacral screws without any imaging at all at this point. I mean, I've done enough of them. I still have significant angst putting in thoracic screws. I was trained in the era of hooks for deformity and then transitioned to screws, but I still don't like putting screws in the T-spine. 7D is an absolute game changer. Changes patient safety profile, incredibly speeds up the cases because you know where you can and can't put a screw. You have immediate feedback. Sometimes in a deformity case, you'll have on the concavity of a thoracic curve, you'll have a 2 or 3 or 4 millimeter pedicle, and not even to try. Where in the older days, I would spend 20 minutes poking, hoping, jabbing, trying to get that screw. Now I know that it's hopeless and move on and transition if I need fixation there to either a hook or a sublaminar band. So cases have really significantly speeded up. Even the traditional, lumbar sacral deformity cases go faster. And the other thing it's enabled me to do is to do some marketing. The company doesn't actively market for me, but in the deformity world, you get these young adults, these 20 to 30-year-olds who are very internet savvy, and they do a lot of research before they choose a surgeon, and they come to me for a second or third opinion, and they say, why you? And I say, here, look up this company, and I give them the 7D website, and they all call back. And I'd also like to point out, the trauma center I work at is a 1,000-bed hospital. They've got a ton of people that do spine. They have 8 employed neurosurgeons. And there's 24 orthopedic spine surgeons in downtown Orlando. And they have all the bells and whistles. You know, they've had an O-arm since the day it came out. And I've used an O-arm in a couple of cases. I used it in a young adult, small stature deformity case. And it added, the first case I did with the O-arm added probably 4 hours to a case and turned what should have been a 6-hour case into a 10-hour case, and I was frustrated. And I tried it a couple other times, and it just is not worth the hassle. 7D is a totally different beast. Go on. Just going to share with you a few cases. These are the cases where I think, you know, 7D really makes a difference. If you have deformity cases, things are rotated, things are tilted, distorted. It's just a beautiful moment-by-moment feedback in three-dimensional plane. And the machine is really what they say. You can operate this with a foot pedal. Every now and then the engineers come down and I ask them not to touch my machine. The thing is totally surgeon-driven. I have 2 physician assistants who know exactly how to load the scans, the preoperative scans, how to template. One of the best operators of this 7D system is actually my implant rep. One of the implant reps is a virtuoso in getting this thing just perfectly set up. It only takes about 5 or 10 minutes to get the scan loaded and templated. So this is the case of a 21-year-old lady that has a painful progressive thoracolumbar kyphoscoliosis. Really, her main source of pain is the shark fin Shorman's kyphosis. She had been treated on the east coast of Florida for about 3 years, non-surgically, had been on narcotics for about 3 years by the time I saw her. Her surgeon actually told her that she needed to have bariatric surgery before he could operate on her, which she did. She went from about 350 pounds to about 250 pounds. He told her that he didn't feel comfortable operating on her. I was her third opinion. Basically, like I said, short, sharp thoracolumbar kyphosis, 67 degrees and a 47-degree left thoracolumbar curve. You can move on. So this is on the left, the image of the reference arc attached to her L3 vertebrae. And basically you attach that reference arc, tell the machine where it is, push the foot pedal, it flashes, and you get the image on the right. And again, green means go. I've had enough experience with this machine now that I can tell instantly from looking at that picture I get on the right whether or not I've got adequate exposure for navigation. The answer is that you have it about 98, 99% of the time. The only exception is really sometimes the lumbosacral junction, especially in a man with a tight pelvis. It's sometimes hard to see the sacrum. So each of those little dots is the point that it's correlated with the CT scan. If you get enough of them, and again, once you have a little experience, you can tell instantly. You verify that things look good and you move on. So again, 1,641 localized points between the CT and the intraoperative flash. That flash literally takes 10, 15 seconds. This is an intraoperative, this is what you see basically on the 7D screen while you're monitoring. So in my institution, we have monitored awl and a monitored pedicle probe. There's also available a monitored drill, which my institution, which was in the process of being purchased when I asked for the drill. So there was a freeze on all capital spending. We have that on order, and there have since been dynamic arrays, FDA approved, which you can attach to any tool. But you get instant feedback as to the diameter and the length of the screw you're going to put in. You can see that that vertebrae is pretty rotated. You can see that that pedicle is pretty narrow. One thing that's really changed is I have put in a lot more 5.5 screws since I've had the 7D than I ever did. You know, I'm willing to accept a little bit of a lateral breach if you need to get fixation. Not willing to accept medial breach, but you know, I used to just by default put in a 6.5 screw in almost every pedicle. This case, clearly you can see that that's not going to take a 6.5 screw, but you can safely get in a 5.5, and I've even in some of these deformity cases put in a 4.5, which I think prior to having the 7D, I don't remember ever putting a 4 or 5 screw in a thoracic spine. Move on. So this is her post-operative film. Her kyphotic deformity is significantly improved. Her scoliotic deformity is significantly improved. She's got really what preserved L5-S1 junction. perfect disc on MRI, which is why we stopped at L5, gave her a little area to move at her lumbosacral junction. 3 months post-op, she's off of narcotic analgesics. She was on them for about 3 years preoperatively. She works as a caregiver for mentally handicapped kids and has returned to unrestricted activity as a caretaker. This is another perfect case for the 7D. I do a lot of cervical spine surgery. I do a lot of posterior cervical surgery because not a lot of guys, well, there are a lot of guys in town who don't want to do it, and it gets referred. This is a 68-year-old gentleman who came in. He's got, you can see, pretty severe cervical TJD. He's got a cervicothoracic kyphotic deformity, pretty tight stenosis, and an element of a congenitally small spinal canal. You can see there at C3, 4, 5, 6, his pedicles are short. Myelomalacia, had some spasticity in his lower extremities, killer right arm pain and right arm weakness. He's right hand dominant. So I don't have any issue at all putting in lateral mass screws, you know, C3 to 7 with C-arm, or even blindly if you have to. I have a lot of issue with putting in T1, T2, T3 screws blindly, or even with C-arm. You know, that's an area where frequently your shoulders are in the way. You bring in the C-arm and, you know, you're going with a poke and a hope from the AP image. You can't see anything on the lateral. 7D is just an absolute game changer in terms of level of comfort with a case like this. So this is, again, the reference arc. At C3, you can see there's a bunch of green, which is a very good sign. We'll go to the intraoperative images. This is a little scary. So those of you who do or have done a lot of posterior cervical, you know, it becomes fairly straightforward to follow the contour of the lateral mass and the angulation out and the angulation up. You can see this guy's got pretty arthritic lateral masses as well. It's kind of scary, though, to look in there and be able to see the foramen transverse area and how close it really is to your screw. And in all honesty, and if I have a routine, you know, posterior cervical of C3 to 5 or 3 to 6 or 3 to 7, I don't always get a 7D. And part of the reason is that I'm comfortable putting in screws, and I think sometimes being blissfully unaware of how close you are to the vertebral artery is probably a good thing. But in cervicothoracic cases, it is an absolute necessity. So this gentleman had a C3 to T2 decompression instrumented arthrodesis. We reversed his kyphosis to the point where it would let us. And my rule of thumb in these cervical cases with myelopathy is I get preoperative flexion extension x-rays, and I try to never correct them to more than their voluntary degree of extension. If I do, if they're really deformed, then I will decompress them, put the screws in, and then put them into more lordosis before locking them in with the rods, just to make sure there's plenty of dorsal room for the cord to expand. But you can see that these screws in T1 and T2 are just absolute bullseyes. I did CT this gentleman. He was one of my first cervicothoracic cases, and those screws are just directly in the heart of the pedicle. C7 is skipped just to make it a little easier to contour the rod. You can see that those rods hit way lateral. So he had good resolution of his spasticity and good resolution of his arm pain. By 3 months, he was actually asymptomatic, still had a little hyperreflexia in his legs, but had absolutely no symptoms. This is another great case. This is a girl's 23-year-old female with a painful progressive scoliosis. She actually has a 75-degree T6 to L1 curve. These are her unbending films, and this goes along with what I was saying. I was her third opinion. She came from Tampa. I'm in Orlando. Her regular preoperative AP and lateral x-rays were done on film with her surgeon, and she took them back. These are unbent films we got when she came into the office. She's got a pretty stiff curve. She only corrects to about 40 degrees on her maximum right lateral bend, as you see there on the left, and a left bend, and no comment on the jewelry. We'll move on. She ended up with an instrumented arthrodesis, T4 to L2. This is the reference arc on, I believe it says T8, but over my images over that on the slide. A lot of green, and again, you know, if you get that much green, you're going to get an ideal navigation. The thoracic spine, you know, the beauty of this technology is that it's best where you need it to be best. So the closer the bones are to the skin, which is in the thoracic spine, the better imaging you get, and basically it's a no-brainer. Every shot you take in the thoracic spine, you get a clear, great navigation, and I haven't found it ever to be off at all. We got it February or March of 19, and I thought it was the most awesome thing I had seen. And then they did a software update in the middle part of 2019, and it was twice as good. And I tell people that, you know, if you try it, you won't believe it. Anyway, so again, thoracic screws, putting, you know, screws in T4 to L2 in a normal 23-year-old, bright, smart, happy girl. The thing you want to do is do no harm. And this, I think, technology makes me that much more sure that I'm going to do no harm. Should move on. You can see that she is really rotated, and she was really rotated. This is a cannulation of an upper thoracic pedicle. The beauty of this is you can see two things. The pedicle on the concavity that's not being instrumented, you look at that pedicle and you know instantly she's got a 3-millimeter pedicle. You know, it would be foolhardy to try to put a screw in there. And in fact, I did not try to put a screw in there. And that's one of the things that really increases surgical flow. You get a level by level feedback of what you can and can't do and how to most safely do it. And if you look at the pedicle that's being cannulated, it's probably only 4 or 5 millimeters. And what I'm doing with this angle of entry into the pedicle is accepting a little bit of a lateral breach, which is safe, and getting that screw right into the ventral part of the vertebral body. And it's, the technology just enables you to do amazing things. And you can see from the sagittal recon, it's right down the heart of the pedicle. So this is a 7-month post-op picture. Her curve's corrected to about 15 degrees. I don't think I can have the ability to point, but on the concavity of her curve, where we skip the screws, I use sublaminar bands to derotate her spine. And I tend to do that in anyone with a lot of rotation in the apex of their concavity, or where the pedicles tend to be most dysmorphic, and I find a lot of ability to derotate by using sublaminar bands connected to those rods. So we got her curve corrected to about 15 degrees, even though her unbend film was about 35 degrees. She's basically pain-free and a happy camper. This is just another interesting case. This is a lady that I had done a T10 to L5 fusion on 12 years ago. Oddly, you would think that her lumbosacral junction would break down, but her lumbosacral junction was perfect, and she was actually pain-free. Had a fall and suffered a disc herniation at T910. She's got some proximal junctional, little bit of kyphosis. Got actually some myelopathic signs, some lower extremity spasticity, intermittent urinary incontinence. And we extended her fusion up. We can move on. Extended her fusion up to T7. The left image is the intraoperative flash. The really cool thing is you can even see the color of her screw heads on there. That is taken coral instrumentation. They're pretty purple. You can see the tremendous amount of matching points, over 3,000 points matched on the level above. Like I said, amazing technology where you need it to be amazing, which is in the thoracic spine. So in a case like this, I wouldn't bring in fluoro. I know where those top screws are. I can count my levels up from there, and I just go in and basically start instrumenting the vertebrae above. And as I said, in the thoracic spine, it's fabulous where you need it to be fabulous. So this is the image of T7. So we went in and instrumented 7, 8, 9, used rod-to-rod connectors to connect to her existing instrumentation, did a laminectomy, markedly improved, restored her normal sagittal balance with minimal effort, minimal risk to her, and minimal operative time. So at 3 months post-op, her spasticity improved, pain has resolved.